everybody. First of all, I would like to thank the Data 2 Conference Committee for giving me an opportunity to present this case report. This is a 9-year-old girl with recurrent rupture abdominal aneurysms in Data 2 successfully treated with infliximab. I would like to present the clinical manifestation and lab data. This is a 9-year-old girl. She was referred to our hospital with 3 months history of severe intermittent abdominal pain, hypertension, renal infarctions, and history of stroke for 2 years. Her MRI brain revealed multiple old lacunar infarction in the basal ganglion, left thalamus, midbrain, and pons. The MRI brain showed no significant stenosis or aneurysms. On admission, day 1, she was fully conscious with mildly pale and with high blood pressures. The abdominal examination at the time revealed no distension, no tenderness, or no hepatosplenomegaly. The neurological examination revealed left hemiparesis with a muscle strain grade 4. Her lab data at first time revealed only mild pallor with hemoglobin level of 10 gram per deciliter and normal white blood cell count, platelet count. Her set rate was high with 79 mm per hour, and CRP level was also high with 77 mg per liter, and ASO titer was positive. She had normal urinalysis with normal liver and renal functions. At that time, no evidence of hepatitis B infections, and count was negative, and complement level were normal. As you can see on the CT at the first time, in figure 1 on the right side of the poster, the axial and coronal maximal intensity projection image show multiple aneurysm of intra-abdominal arteries, including branch of SMA. After that, we decided she was probably have polyhydramnionic nodosa, so 3 doses of pulp methylprednisolone was given, followed by intravenous cyclophosphamide. Antihypertensive medications were also prescribed, including atenolol, amlodipine, hydralazine, and nifedipine. The patient's blood pressure was quite difficult to control because of her severe intermittent abdominal pain as well, and she subsequently developed massive lower GI bleeding and hematologic shock on day 24. She was transferred to ICU, but component and intravenous immunoglobulin 1 gram per kilo per dose for 2 days were given. But the GI bleeding still continued. So emergency angiography was performed at that time. And you can see in figure 2, you can see that on the white dash arrow, it must show multiple small aneurysm at jejunal branch of SMA. And you can see on the black dashed arrow here, the aneurysm that's already ruptured. And you can see the contract extravasation below that. And also multiple stenosis or branch of SMA is also seen around here. So it's quite very difficult cases. So we decided to do the arterial embolization at that time, and it was successfully performed. But 3 weeks later, after the 3rd dose of IVCY, she developed 3 recurrent episodes of severe lower GI bleeding again. However, this time the embolization was failed. So, and the angiographic examination did not demonstrate any contract extravasation or bleeding. It's probably due to the vasospasms. So therefore, we decided to give her with infliximab, a chimeric anti-TNF monoclonal antibody, around 7 mg per kilo per dose. We decided to give her every 2 weeks for 3 times, then every month for 6 months, along with other supportive treatment. You can see the summary of hospital costs in the figure 3 below. So she responded well to the infliximab therapy without any side effect and was discharged from hospital on day 166. At the 6-month follow-up visit, her symptoms were markedly improved. Her abdominal pain and hematochezia were resolved. Her blood pressure was controlled by only atenolol and amlodipine. Her neurological sign remained stable. The CTA of the whole aorta was done again and revealed the sum of aneurysm had decreased in size. As you can see in figure 4, the axial maximal intensity projection image here show decreased size of previously mentioned aneurysm of the branch of SMA, but the coronal image show disappearance of the large aneurysm at jejunum. So she was able to return to school and was satisfied with this treatment. After discontinuation of infliximab, azathioprine was started for long-term maintenance therapy. At the 1-year follow-up visit, her disease was controllable with azathioprine and a low dose of a steroid. She had no abdominal pain or GI blood loss. Her blood pressure was controlled with amlodipine and atenolol. After patients successfully treated with infliximab, DADA2 was suspected, and further investigation were performed. The lab data show no detectable ADA2 activity and mutation in the ADA2 gene. Therefore, from this case report, if we have children with refractory polyarthritic nodosa who fail to respond to conventional treatment but have a good response to anti-TNF therapy, should be suspect of DADA2. This case report was published in Biologics, Targets and Therapy in 2019, but due to limited resource, we did not further work up for DADA2 before publishing. But we would like to thank Dr. Shiv Chamber and his team for helping us further investigation for DADA2. Thank you very much.